Oh, sweet. Okay. I've literally stuck a note to my monitor saying remember to record. Right. Hey guys, hope everyone is keeping safe and doing okay. So we are going to be doing some more psych today. So as usual, starting with case, because cases are fun. You've got this lady, Serena Bolen, who's 32. You're the F2 on liaison psych, and you've been called to assess this patient. So ED brought her in on section 136. Anyone want to say what section 136 is? But in the meantime, while someone's saying that, basically the police brought her in because she was found running through traffic. She was swearing at people who were driving big cars, telling them they're going to hell for destroying the planet, and that she's doing the will of Allah. There's no evidence of any acute physical illness, so she's an ED. They've checked her obs. Obs are fine, so ED doctors haven't seen her, but she's not on the patient record systems that you have access to. And yeah, perfect. So Janice said police 136 is police bringing someone from a public space to a safe space, which is different to a section 135, which is when the police bring someone from their own home or private property. So she's not on the patient record system, so this is probably a new patient. So you're going to go see her. Now, let's say you're going to do her mental state examination. So someone run me through the parts of the mental state examination. I'll answer as if I was the patient or what you are seeing. So run me through your mental state. Mental state examination, not your mental state. You can do that later if you want. Always here to talk. Appearance and behavior, good. So you've got this young lady. She looks quite well kempt. She's quite fidgety. She's struggling to sit still, but she's not running around the room or anything. She's making good eye contact. In fact, she's barely looking away from you, and she's sort of repeatedly trying to lean over and sort of grab your hand, not in an aggressive way, but just sort of hold handy way. And there's no concerns from a medical perspective about her. She doesn't seem physically unwell. Okay, next step. Speech, yeah. So she's speaking really, really quickly, and she's quite loud. She's not screaming or shouting, but it's not like she's intentionally trying, but she is quite loud. So rapid speech, tone, she's not angry. She's just sort of seems happy to be speaking to somebody, and she's going quite fast. Okay, next. Affect and mood, perfect. So you ask her how she's feeling. She said she has never felt better in her life. She now knows her true purpose, that she's the true messenger, and she needs to save humanity from destroying the environment, otherwise the apocalypse is coming. Her affect's very expansive. Like you can almost feel the energy coming from her, as if sort of it's like a radiator giving off heat, except this is a person giving off so much energy, almost larger than life. So her affect's expansive. Perfect. Next step. You're doing really good, guys. Thought form. Perfect. Okay. So her thought, the form of her thought, she is speaking so fast. It's almost like someone's told her she's got a minute left in an Oski and she hasn't, she's nowhere near finished with talking. So she's speaking incredibly fast, and she's quite kind of jumping from things. She's jumping from topic to another. There doesn't seem to be much of a link between the topics. What's that called? So she's rapidly. I'm sorry, Anush. Yeah, so night smooth thinking or derailment. Night smooth thinking is quite an old school term because one step forward, two to the side, or two steps forward, one to the side. So she's displaying, so it's also called derailment, as if a train has sort of come off of its tracks. And some people nowadays call it tangentiality, just coming off of, just going off of different tangents, which are barely linked to each other. So, whereas, though technically the term tangentiality is when the ideas are quite related. So yeah, I'd call this night smooth thinking or derailment. And she's displaying flight of ideas because she's going from one topic very, very quickly to the other. Okay, And in terms of, so that's thought form. In terms of thought content, what sort of things do you want to ask her when you're assessing her thought content? So there's three sort of important things to assess in thought content. Yep. So she's denying that the feeling that anyone's putting any ideas in her head, that anyone's taking any ideas, that people can sort of read her mind. But in terms of if you're assessing for risk, there are three really important things that come under thought content. So Valeria is absolutely right. You do want to assess for those. Absolutely. Good. Suicidal thoughts is really important. She denies thoughts of, suicide or self-harm. What else? What's the next thing? Perfect. So homicidal thoughts, she denies thinking, of harming anyone. In fact, she becomes quite irritated because she says she's here to spread a message of love and to save people. So vulnerable to being harmed, Janice is going to come under risk assessment, but we base that decision based on the other things that she said, but that's really, really important. And the last thing is going to be any delusional beliefs. So, because that can predict a person's behavior. A person who believes that they are being hunted and is afraid for their life is far more likely to behave erratically and be a risk to themselves or other people than somebody who doesn't think that they've got anybody after them. So she's again sort of repeating this thing that she's God's final messenger and must stop the apocalypse. So we've got grandiose delusions. She denies homicidal thoughts. In fact, becomes quite irritable when she's asked about those. And she say, "Why would I ever kill myself? I feel great." Okay, next thing. So brilliant. You've got thought under lock, which is thought is probably the most extensive part or the most important part of the mental state examination. Some people elongate it sort of thoughts and feelings. Okay, so she doesn't feel like anybody else owns her thoughts, so no thought possession. But so we've done appearance, behavior, speech, sort mood and affect, so emotions. We've done thought. So what's the next thing to assess for? Perfect, perception. So she, in terms of perception, you are asking her about voices, and she says, yeah, she does hear a voice. She says it's God's voice, and he's telling her to spread his message. What are the important things to ask about when somebody reports that they're hearing voices? Yeah, perfect. Are they derogatory voices? No, the voice isn't insulting her. Just sort of instructing, telling her that she's his messenger and to spread the message to save humanity. What else? What else do we want to know about the voice or voices? So I guess that was one clue. How many of them are there? Is it one voice? Is it more than one voice? What else is important with voices? So what they're saying is what Janice has alluded to. So what are the voices saying? How many voices? Yep. So insight will come under next step. But is it very? Okay, perfect. How do you hear the voices? Are the voices coming from inside your head? Are they external? External is more in line with a psychotic illness. Internal is more in line with sort of severe personality disorders. You'd call that quasi-hallucination. So she says that the voice is coming from above. It's not from inside her head. She feels it coming from above, from the sky. Are they talking to her or about her? The voice is talking to her, not about her. So good. So is it a first person, second person, or third person hallucination? And the voice is talking directly to her. And the last thing, which is important in terms of the risk assessment about voices, let me just check if somebody's already said it. Don't think so. What's important thing if someone's hearing voices? What are they telling her to do? Or yeah, perfect. So command hallucination. So so they are checking for if there are violent command hallucinations because it could be a risk to self if they're telling her to hurt herself or risk to others. Perfect. Very good. This moves us on to the next step, which is what Miguel alluded to, which is insight. So in Insight, a really important thing that you will pick up if you do a psych job is Insight's a really hard step to approach, and it should be done carefully, because if a patient is psychotic, remember that this is all real to them. It will just aggravate them if you tell them something like, this isn't real, right? Or do you understand, do you understand that what you are experiencing isn't real? So usually the way that you might approach is, do you think that what might be going on is a mental illness or not? Something along those lines, something sort of less confrontational than just immediately going, do you know this isn't real? So you sort of propose to her that, do you think you might be unwell? And she gets quite angry at that. She thinks that you're trying to silence her from carrying out God's work. She doesn't think that she's unwell. She'd absolutely not be open to the prospect of an informal admission. So where she consents to the admission. Perfect. And then the last part, the last part of the mental state exam, cognition. Perfect. And she knows where she is, she knows what time it is, and she knows who she's talking to. She knows that you're a doctor, so she's grossly orientated to time, place, and person. Perfect. Remember your aseptic mnemonic for the mental state exam, which all of you've basically got. Well done. If this comes up in an OSCE, you're all set. So let's talk about risk assessment. So quickly, can people run me through the sort of steps of the risk assessment? So what domains are there to a risk assessment? There's three main ones. Some people add on a fourth. Oh, let me know what you think. What are the domains? Perfect. So risk to self, which is a huge one. Risk to others. Perfect. Like Valerie has said, and risk from others. And then the fourth domain that some people add is risk to health. This is a bit of a confusing one, but the way I like to look at it is risk to self, for example, is if the patient is thinking about killing themselves or cutting themselves, so self-harm. Risk to health is more to the physical side of things. So if somebody is so depressed that they're not eating, and, for example, somebody with an eating disorder and they're incredibly hypokalemic now, that is risk to health. So risk to self is more of the direct influence of their mental health on sort of risk to limb or life. Risk to health is sort of an indirect effect on their physical health. Right. So let's say we are talking, so you're trying to take the history. So what things do you want in the history from this patient? Remember, follow your structure and you'll be all good. Each one of you can do this perfectly, as long as you stick to a structure. Perfect. When did it start? So she said she started feeling like this a few weeks ago. It came on quite suddenly. She just woke up and she sort of realized that she had a purpose and she heard God's voice. That's what she knew. Yep. So onset is always important. So we have Socrates for a pain history. I like turning it to OATS for any other presenting complaint. So OATES, onset, associated symptoms, time pattern, exacerbating, relieving, and severity. Any trigger, not that she can think of. Not that she can think of. You ask her about work. She says she's an accountant, but she can't really, she just sort of says, I guess God decided that was the moment. She's not bothered by it at all. Really good question. How bothered is she about it? She is overjoyed. She knows what she's, she knows her true purpose now. She is delighted. What things are sort of important in a query mania history, query hypomania, which also contribute to risk assessment? So if there were sort of nuggets in a 10-minute OSCE station, and you were asked to do a sort of risk assessment, and this is a patient who's manic. Good. So past psych history, she says it's never happened before. Very good. No previous episodes of depression. Fantastic. That's really good. So there's no past psych history. Only medicine she's taking is Cerazette. What is Cerazette, guys? She's got no known allergies, by the way. So it's not the combined. So, yeah, perfect. So it's a progesterone only pill. Good. So she's only taking contraception. Perfect. So no other medications. Anything else? What medications are we always on the lookout for? I know she said no other medications, but just to double check, what medications are we always on the lookout for a psych presentation, especially a new one? Clue. If you get it right, a neutral immediately heart your answer. What meds do everything as a side effect, including potentially mess up your mental state? Steroids, yes, perfect. Yeah, perfect. Specifically corticosteroids, yeah. So steroids, so she's got none of that. What about sort of if we're talking more history of presenting complaints? So we've got that she's started feeling like this a few weeks ago. Past psych history is nil. Past medical history is nil. She's just taking Cerazette. She's not allergic to anything. What things in a mania history are important? If we're thinking about risk, what ways might somebody who is experiencing a manic episode or a hypomanic episode possibly put themselves at risk? Not necessarily just physical. If you're disinhibited, what things might you do? Yep, so you can query about delusions of grandeur, which we got from mental state. Yes, good. Overspending is really important. The number of people with bipolar who end up needing some form of financial support because whilst they were manic, they spent their savings, bought things they couldn't afford is ridiculously high. And you will see it if you're in an inpatient ward. A lot of people need financial support with that. Change in behavior and risk taking, perfect. So a really important one, which often gets forgotten, is risky sexual behavior. So you've got the obvious ones like things like walking into traffic or things like that. But if somebody has become entirely disinhibited and because they're manic, their libido's gone through the roof and they're sleeping with tons of people, there's almost two elements of risk there. So there's the physical element, which is if they're not using protection, what are the chances of them picking up a sexually transmitted illness, which then goes undiagnosed? And there's also the safeguarding aspect. If you are somebody who is so disinhibited that you are sleeping with so many people, you are incredibly vulnerable to being sexually assaulted, taken advantage of, abused, and that's a big part of the risk assessment. Perfect. Okay. So as I said, she started feeling like this a few weeks ago. She denies needing much sleep, so sleep is always important, and eating is always important. She's eating and drinking fine though. She hasn't been overspending, but she has been having sex with multiple strangers that she's found on Tinder, because she feels she needs to spread God's message through love. She hasn't used any drugs. That's really important. That's one of the most important things in a psych history, because she's saying a messenger of God must remain pure of body and mind. We talked about no physical health issues, no known drug allergies. She's just taking Cerazette regularly. You examine her, which is quite important, and all of that's fine. Her BMI is 21, and there's no sort of peripheral signs of steroid use. She's not bruised, she hasn't got central adiposity. And you do a pregnancy test, because always do a pregnancy test, and it is negative. Okay. She's also given you, you ask if there's anybody else you can talk to, and you've got a collateral from her mum. Her mum also says that there's, even though Serena lives away from her, from what she knows, she hasn't had any medical or mental health issues in the past, so she corroborates what her daughter says. She says, yeah, she works as an accountant. The thing that has been quite useful is that you find out that Serena's great aunt had some form of mental illness. So this is her mum's aunt. She doesn't know what it was, but she knows that she was in hospital with it quite a lot and she needed long-term care. She doesn't think that Serena uses any drugs. So we talked about risk assessment. We talked about the domains. So quickly, what is Selena's risk to herself? Would you say low, medium, or high? Direct risk to life and limb. And justify it as well for me. Okay, medium, high. Why? She's not suicidal. Why do you say her risk is high? Okay. Risky sexual behavior, which I would put down as risk to health, because that's not going to immediately kill her. But that's very important, yeah. How was she found? Where did police find her? And this is one chat comment up, which is, I don't know why it's done that. But what's the scary thing about how she was found, which could have gotten her killed? Yeah, running through traffic. So high risk to self because of that. Just because somebody's not suicidal doesn't mean they're not a risk to themselves. If you let someone go and the first thing they do is go to the top of a building because they think they can fly, that is high risk. What about risk from others? Where do you put that up? Low, moderate, high? Sophie, you've already basically answered that with the second part of your thing. So she's swearing at strangers and insulting them, so it's increasing her risk of assault. And Clarine has mentioned risky sexual behavior, which we said increases her risk of being taken advantage of, raped. So where would you put her risk from others? Yeah, I would agree with Janice. You might get away with saying it's moderate, but I'd put it as quite high. What about risk to others? What's her risk to other people? I'd say it's low. She hasn't said that she's feeling homicidal. It would be important to get her forensic history, something which I forgot to mention. But let's say that she's got no previous convictions, no violent history of violent crimes. I'd say it's fairly low risk. And with a BMI of 21, she's probably going to be quite a slight person. She's probably not a muscular, hulking person who might be able to, with one punch, knock somebody out. They hit their head, get a subdural hemorrhage, and die. And risk to health, kind of already mentioned. So while she's not self-neglecting, if she's running around traffic and risk of an STI, that's at least moderate. So, are we happy for this lady to go home? As a collective, as the psych team, are we thinking, yeah, she can go home? We can call her mum and say, yo, can she stay at your place for a bit until she's feeling a bit better? Yeah, perfect. Yeah, we're not sending her home. Even though she is saying, I need to get out, there is no reason why I should be here. I need to be spreading my message. This lady's in danger. What do we need to do before we make any psych diagnosis? This is something I always want, I want everyone to have drilled in. What is important before we make any psychiatric diagnosis? Yeah, perfect. Excluding organic cause. Remember, you are medical students and you are going to be doctors. Even if it's a mental health issue that is being presented, exclude the physical stuff. That's what makes you different from psychologists. So, SBA time. What do you want to do next? What's sort of the most appropriate thing to do next? Because realistically, you could do any of these, but what's the most appropriate next one? So I'll give you 30 seconds because this is a single step SBA, and then we'll see what people have to say. Okay, and I completely agree with Larry. It is a urine drug screen. Now let's talk about that. CT head, sure, first presentation, but you might do it later. It's not urgent. It's not going to change your treatment right now. TFDs, absolutely. You'll request them. You'll take those bloods. Same with D, the full blood count and CRP. But it's just way quicker to take a urine drug screen. You'll get the results way quicker, and that is by far the most common differential for a psychiatric presentation, especially the more up ones, so psychosis or mania, somebody has taken something. And blood lithium levels, you've got no evidence of previous interaction with mental health services, so you might do it, but you've got no real reason to do it, and I don't think it's the cheapest test either. What now? So let's talk about other investigations. So you're not doing the CT head now. Let's say her obs are stable. Urine drug screen. So the things that usually come on the urine drug screen are cannabis. Important thing about cannabis is that one lasts in your system for ages. So you can test positive for cannabis 28 days after you've actually used it. You've got cocaine, amphetamines, which actually go out the system very quickly. So somebody might still be using them, but if they've used them a couple of days ago, they might test negative. Opiates and benzos are the other two that come on basically every screen. You might have some fancy ones which bring up other things, but let's say she's tested negative for all of those. Tell me bloods. So we're doing her FBC and CRP. Let's do a fun bit of clinical justification. Why do you want a full blood count and CRP? What is benefit? Because you're going to do them practically everybody. If she goes to the psychiatric ward, they'll do them there as well, but why? She could have infection. Perfect, yeah. It'd be really silly to miss a she might, yeah. It'd be really weird if she had a meningitis, considering how physically she's just chilling, but you want to see if there's an infection. Or, there might be two separate things. She might also have an infection going along. You might want to treat it. Use and ease. Why do we want her use and ease? There's the obvious answer, which anytime somebody says, why are you doing use and ease, you can always say to, because it'll influence treatment. If they've got a poor renal function, I might not be able to use certain drugs, which is a perfect cop-out answer, because it's always true. But what else would use and ease be important for in this lady? Let's say you've added on bone profiles. Yep, hydration status. Yep, she's 32, so delirium is unlikely. But there are some metabolic disturbances, electrolyte disturbances, that can present with psychiatric causes. It'd be really weird for her to be hyponatremic and coming in manic, but it does happen. You add a bone profile probably as well to calcium, because hypercalcemia can present like this, and does, and people get surprised by it. Okay. Why might we do her LFTs? What the hell would LFTs have to do with this? Good. So if she maybe she hasn't reported that she drinks a lot. What's another thing with the first presentation of a psychiatric condition in a relatively young person? We know that she's got no neuroscience, but yes, Wilson's perfect. It gets missed. It's stupidly rare, but I have read cases where it gets missed, and the problem with it is after a while, if you haven't treated it, then it's irreversible damage. So it doesn't really hurt to do that. So what investigations are we going to do for Wilson? So LFTs, but specifically what else are we going to add on for Wilson's? Urine copper, good. And in Wilson's disease, what will that be? And what's the other one? Yay, perfect. Serum copper and ceruloplasmin. So just quickly, what will those be? Oh, whoops. Oh, we talked about that. That's fine. Yep, serum stuff low, urinary high. Perfect. Yep, because all of your copper is being bound to your ceruloplasmin. So your serum is low, and your urinary copper, because that's all being taken out, is high. So serum copper low, and yeah, perfect. Right. So, and you can't really detect the ceruloplasmin because it's all being bound to copper. Right. So we've done neuro autoantibodies because it could be an autoimmune encephalitis. We've also done HIV, Hep B. What is EIA? What's that testing for? What is EIA a test for? Yep, it's the enzyme immunosorbent assay. And what can we use it to? What can we use it to diagnose? Clue is next to HIV and Hep B. Syphilis, good. We want to diagnose syphilis. Perfect. Okay, so that's all normal. So we're kind of happy that there's nothing organic going on. What we're going to do now? So we excluded anything physical. So do we want to refer Selena to the crisis team who will manage her in the community? So maybe they'll see her every day. Do we want to arrange for a mental health act assessment to assess if she needs to be admitted under Section 2? Do we want to do that but assessing for Section 35? Do we want to detain her under 5.2? Or do we want to admit her into a medical ward to await her CT or ACT and detain her under a 5.2 in the interim? I'll give you another 30 seconds for that, just so we get a bit of a move on. Oops. See what you all think. So, what are people thinking? Anyone have any idea or thoughts? So I agree with B. Would you not do D because of the major findings from the history? Sorry, Janice, I don't quite understand that. What do you mean by would you not do D because of the major findings from the history? Whilst just saying that, just quickly say, yeah, B is the right answer. So quickly going through it, we said A is wrong because we're not going to send her home. B is correct. This is a first presentation, so you want to admit her for assessment. Remember, Section 2 is a 28-day assessment order. C would be right if she was being seen in court. Let's say she'd committed a crime, and then they'd taken her to court and gone, "Oh, we think you might be mentally unwell." That would be a Section 35. It's the forensic equivalent of a Section 2. D, this is important. I didn't know this until earlier this year, actually, start of 6th year. 5.2s can only be used when a patient is admitted as an actual inpatient. So once they've been accepted by one of the teams, if they're an ED, they can't be doing it at the moment. So if they've been, okay, well, we're going to admit them, the medics or the surgeons have gone, we'll admit them, then you can do a 5.2, but otherwise you can't. And then E would be right because you've admitted her, but we're not going to do that because she doesn't need a CT. You can just do it later on when she's a patient on a psych ward. So B is the right answer. Quick recap for everybody. Sections 2 and 3 are the only ones where you can treat people against their will. Every other section is leading to, this is not including, we're not going to talk about the forensics because they're not really important for you. All the other sections are trying to lead to a 2 or a 3. So all the other sections are holding orders, which give you time to detain the patient until somebody can do a proper mental health act assessment to see if they need a Section 2 or a Section 3. And 2 and 3 are the only ones where you can treat somebody against their will. Okay, so let's talk about bipolar real quick. So bipolar isn't uncommon. Global prevalence of 1 to 3%. 3, I think, is a bit of an overestimate. It's about 1%, so it's more common than schizophrenia, actually. And it's got a really high heritability, so there's a strong family history aspect to it, and there seems to be a lot more sort of biology to it than psychology, let's say, compared to something like depression or your personality disorders, your eating disorders. In fact, you could say schizophrenia and bipolar are probably the most biological of the mental health, of mental illnesses. So by definition, bipolar, two poles, you get periods of sort of reduced affect and mood, which is your depression, hypothymia, and periods of increased affect and mood, which is your hypomania and mania. There are three types. You've got bipolar 1, which is technically the most severe. That's mania and depression. Bipolar 2, which is the most common and still really debilitating. That's hypomania and depression, and cyclothymia, which is not very common, not often diagnosed, which is when people alternate between dysthymia and hypomania. So the important thing to sort of educate people about, because there's a common misconception with the idea of what bipolar means. Bipolar does not mean the patient is 1 second to another flitting between feeling on top of the world to incredibly depressed or in tears. That's more in line with emotionally unstable personality disorder. Personality disorders we'll cover in a later session. But even patients who have rapid cycling bipolar, and rapid cycling bipolar is defined as 4 or more episodes of elated mood, so hypomania or mania a year, even they don't really do that. So you've got type 1, type 2, and cyclothymia. There are other types, which psychiatrists will talk about, like type 6, steroid-induced bipolar, but don't worry about that. That's more of a research and disputed thing. So let's talk about mania and hypomania. To diagnose those, so this is based on the ICD, because that's what we use here. New for the ICD-11, which comes into force next year, to diagnose mania and hypomania, imagine these are the core symptoms. Like with depression, I have low mood, anhedonia, and fatigue as your 3 core symptoms. In bipolar, or mania or hypomania, you've got 2 core symptoms, which is they need to feel euphoric or irritable or expansive. So remember, they're not necessarily happy, they might be really irritable. And expansive is sort of what we talked about, which is you can sort of feel energy coming off of them. And increased activity or feeling more energetic. It used to be just the first one, but now they're adding on the second bit, which is they have increased energy. Then you need at least 3 of the ones that come after that, so 3 of the following, and that could be the pressure of speech or the increased talkativeness. It could be the flight of ideas, the grandiosity, the decreased need of sleep, distractible, reckless behavior, which got mentioned earlier, and things like increase in libido, sociability, or goal-directed activity. The interesting thing is we'll have a lot of goal-directed activity, but then because they're so distractible, it's actually not that productive. You know, if you're hypomanic or manic, you start a project, you have these amazing ideas, but then you kind of get distracted and might end up doing something completely different, and you start loads of projects and never really finish them. Right, so what's the difference between mania and hypomania? Because this is something that some people can struggle with at times. So what's different? There are 3 things really that separate mania from hypomania. Anybody got any ideas? Perfect. If there are psychotic symptoms, if a person is delusional or hearing things, that's automatically mania. Doesn't matter about anything else, it's automatically mania. So mania is at least 7, the time period is regarded as at least 7 days. So in order for a diagnosis of mania to be made, it's either at least 7 days or they need to be admitted to hospital. That's how unwell they are. So far, we said mania needs to last for longer, or if they need admission, then it's mania. If they are psychotic, then it's mania. And the last thing is to do with their ability to function. With hypomania, you can actually get by. You've got loads of energy. Hypomania actually feels great. That's why with bipolar, one of the issues with compliance is that actually when you are hypomanic, it feels really good. You have lots, especially if you've come off of a depressive episode, you have lots and lots of energy and you feel amazing. And then somebody saying, actually, this isn't right. We need to treat that. It's easy to see why people might go, no, I don't want to. This is brilliant. The problem is when it crashes or if it escalates into mania and then somebody's at risk. Mania, they cannot function. So like Liang said, impact on daily life. You cannot function socially. You cannot do your stuff at work. You are being inappropriate. You're putting yourself at risk. So the 3 things are mania is diagnosable if the patient cannot function, needs to be admitted to hospital, or is experiencing psychotic symptoms. One of those is enough for a diagnosis of mania. Because you can have mania without psychotic symptoms, but if there are psychotic symptoms, it's automatically mania. There's the time, so the cutoffs, hypomania is at least 4 days, mania is at least 7. A lot of psychiatrists criticize that. Often with psychiatry, with depression, you need at least 2 weeks, and it's very, very arbitrary, because if somebody's having these symptoms for 2 days, it can still be quite disruptive. But those are the formal cutoffs, but take them with a pinch of salt. Right, so 3 things to remember. Psychotic symptoms, needs to be taken to hospital, or cannot function, that's mania now. Otherwise, it's hypomania. If we talk about the depression side of things, depressive episodes in bipolar are the exact same criteria as a regular depressive episode, so at least 2 weeks. One of the what needs core symptoms plus however many of the additional symptoms, and mild, moderate, severe. Obviously, in bipolar, they tend to be more severe, so you don't tend to get mild depression in patients with bipolar. Dysthymia is different. Dysthymia is an interesting diagnosis because it's subclinical depression, but the duration is much more pervasive. So actually the agreement is that patients need to have symptoms for at least 2 years to be diagnosed with dysthymia. So it's a very odd diagnosis. It's subclinical long-term depression, essentially. But it's not a common diagnosis. You won't see it often with people. And the last important thing to keep in mind is that sometimes patients present with a mixed episode. And this gets really confusing and scary because you have patients who are really depressed, but they've got lots and lots of energy, which is scary because that's suddenly a risk problem. Because if you're depressed and suicidal, if you're really depressed, usually you have no energy, and sometimes that's actually what saves people. They're incredibly suicidal, but they don't have the energy to actually go through with their plans, collect equipment. If you are depressed, but you have energy, that's a lot more worrying. Or you might have people who are manic, but they've lost all of their energy. So you can have mixed episodes. They're uncommon, but they do happen. Right, so coming on to our last SBA, and this is sort of the most clinical bit, which is treatment. So she's been admitted. Now we're thinking about what sort of treatment regime to start her on. And obviously when somebody's in the acute phase of their illness, psychological interventions aren't going to really work. So this is thinking about medication. So we've got 5 options here. So just to quickly run through, 750 milligrams of valproate with PRN lorazepam, 1 gram of lithium with PRN lorazepam, 15 milligrams of olanzapine with PRN lorazepam. Sorry, C should say 2.5 milligrams of lorazepam. I'll change that later. It occurred because I changed promethazine. I changed my mind. I was like, actually, lorazepam. They use both. Risperidone, sertraline, or lithium, olanzapine, and lorazepam. So take a bit to think about that, and then we shall reconvene. So we'll talk medications will be the last bit. Just make a note. Okay. Anybody have any ideas as to what they think the right answer might be? Okay, maybe B. I agree. B. Okay, so let's run through those really quickly. Why is it not A? So that one's a bit of a straightforward one. It's a nice one that you can sort of knock off quite quickly. Yeah, she's a female of childbearing age. We're not going to give her valproate. Perfect. Why not D? Why would D be wrong? Yeah, exactly. An antidepressant is contraindicated if somebody is manic. So we're left with B, C, and E, which are all feasible options. So let's talk about that. So lithium is the first line for a patient who is manic. In maintenance is the key term. That's the cheeky bit. Lithium is gold standard for stopping mania from happening. We can treat it to terminate mania, but it's actually third line for that. First line, if somebody is manic, especially with psychotic symptoms, is actually an antipsychotic. And you have a couple of choices with that, but the first line is that. Later on, if somebody's not responded to 2 antipsychotics, you can add lithium onto that, in which case E becomes the right answer. So you will see people on lithium in acute units. Often, though, that's either because they were already on lithium and it turned out that they weren't taking their lithium, or that the serum level is too low and they're optimizing the dose, or it's combined with something else. And before I go on to the next bit, why have we given lorazepam? Why have we prescribed lorazepam? So lorazepam's not a mood stabilizer, but good shot. Yeah. So what Miguel said, which is for sedation. This is PRN. So sometimes you'll have a patient coming up to you and or to one of the nurses and will say, I'm feeling quite anxious or agitated. Yeah, what Annie said, sort of calm her down. I'm feeling quite agitated. Can I take something, please? And it's always useful to have it prescribed in case a patient wants it. Psych wards can be, they're not a pleasant environment. You have people who are quite unwell, people who are shouting. So it can get really quite, anxiety inducing. The other thing is if she gets acutely agitated, and that's the reason why we've also prescribed it IM. If she's not agreeing to take oral medication, then your last resort is IM. So it's always useful as a junior doctor. One of the things when you're writing up a drug choice, you'll tend to add on a medication for sedation, such as lorazepam or promethazine. Okay, so just to quickly talk through that, we said why valproate is contraindicated. Lithium is gold standard for maintenance, but not really for acute. And first line is generally an antipsychotic. So your options are mostly the atypicals, like olanzapine, quetiapine, risperidone. But that depends, if somebody has already been on them before and responded and stopped it, then you can start it again. If they had horrific side effects to olanzapine and stopped it, then you do something different. Physical comorbidity, this is a big one. I am not a big fan of medicines like olanzapine and quetiapine, especially in people our age. Anybody wants to take a guess why? I am not a big fan of them. They're really effective medicines, but I absolutely hate them. Yeah, the weight gain. People our age, weight gain is a devastating side effect for, because not only is there the social aspect to it, but also people getting metabolic syndrome in their 20s and 30s is horrible. We've said this lady's got a BMI of 21. She's in the healthy range. Olanzapine and quetiapine can make you put on weight insanely quickly. Of course, that's a risk with any antipsychotic, but those two are by far the biggest ones, which is why I've always had a couple of arguments with some psychiatrists about it, saying, no, it's a really good drug. I'm like, yeah, but I hate the side effects. I'd rather take haloperidol than olanzapine. Of course, I've never had Parkinsonian side effects, so, maybe I'm not in the best perspective to speak about that, but that's my position on it. You're absolutely right. Antidepressants should not be prescribed in mania and hypomania, and ideally start with as few drugs as possible rather than jumping to bitherapy with lithium and olanzapine. So this last bit, we'll just talk through the Maudsley guidelines. So these are from 2018 on how to treat people with bipolar. So if they're coming in with acute mania, the first step is stop the antidepressant because it will worsen it if they're taking it. Start an antipsychotic. If that doesn't work, then you can try a different one. So it's the same as with depression. If that doesn't work at its maximum dose, then you can add on lithium. If they're taking lithium already, check the plasma levels. So that's when you do the bloods. If they're taking something like valproate, then up the dose. And if lithium's not effective, then you'd consider valproate in men. An important thing is you don't use lamotrigine in mania. Unlike other mood stabilizers, which tend to cut off the highs, anecdotally, lamotrigine seems quite good for cutting off lows. So it seems good at stopping people from slipping into severe depression rather than stopping people from floating into mania or hypomania, which is why we don't tend to offer it in mania. On the depression side, it's a bit different to unipolar depression, which is start with an SSRI and then progress through SSRIs, then maybe your venlafaxine and thinking about other things. In depression, you usually start with fluoxetine and olanzapine. However, you might go for just quetiapine on its own. Like I said, kind of hate them both, but these are the guidelines. If that doesn't work, you can swap that out for just lamotrigine on its own, and sometimes that can treat it. Or some patients say, I just want to be on olanzapine, I'd rather minimize the number of pills I'm taking. Lithium, if they're already on it, go for the highest dose. That's generally for whether it's manic or hypomanic. If they're on lithium, try to get the dose towards the higher end of the therapeutic range. And if they're already on lithium, so let's say they've come in and they're just on lithium, so you up the lithium and it's not getting better, then you can add on, the non-lithium steps, which is quetiapine or olanzapine plus fluoxetine. Then that doesn't work, you can swap for lamotrigine. Does that make sense? You've got a non-lithium pathway for depression, which is olanzapine plus fluoxetine or quetiapine. That doesn't work, swap it out for lamotrigine. Then you've got the lithium pathway, which is lithium, optimize it, not working. Now add on the non-lithium pathway. And as with the first one, if they're taking valproate, you max it out. Does anyone know what treatment can be done if they don't respond to any of these? So they've got severe mania or severe depression and they haven't responded to any of this. You've tried everything you can. Yeah, so one of the indications for ECT is severe mania not responding to treatment. Perfect. So there are very few indications for ECT. This is one of them. And then maintenance. So this is the last bit that we'll talk about today. At a later session, we'll talk about side effects, especially lithium, because that's quite important if you're going into a medical or surgical job and you've got a patient admitted with lithium. There's lots of stuff that you can interact with lithium, and being able to spot lithium toxicity is quite important. But we'll do if people want to, you can sort of leave this in the feedback section. If people are interested in having a whole session on psychopharmacology, I'm happy to do that, where we talk mainly less about indications and more about things like side effects and monitoring and so on, rather than a session focused on a specific condition. But the last bit, which is with it, so we'll definitely do that at some point. Once the patient started getting better, it's important to have a discussion with them or with their carers or next of kin about starting long-term treatment. And here you've got two options really, which is carry on with the treatment, which they got better with, or what they technically should do is switch to lithium. The problem with lithium, which we'll talk about when we do the psychopharm session, is obviously lots of side effects, and it's a bother in terms of monitoring. Every specialty has got their gold standard drugs, which are amazing at treating the condition, but have horrible side effects. Amiodarone for cardio. Rheumatoid's got a bunch. Rheumatology's got a bunch of them, where there's sort of these godly medications, but their side effects are absolutely horrific. Psych's got two, so clozapine and lithium, which are brilliant medications for treating the actual condition they're designed for, but their side effects will ruin a person. So lithium's first line for that. If the patient doesn't want lithium, you can consider valproate if they're a man, olanzapine if they're a woman, or if they don't want valproate. Important thing is safety netting signs of relapse, and it's really important to talk to the family or next of kin about that, because they will often be the first person to spot as insight starts dropping. Hey, you're kind of slipping up. And if you've got a patient who's been having recurrent episodes, they keep on getting admitted, they don't take their medication, what's an option you can do there in terms of medication? It's a patient with really poor insight, and every time they get, yeah, perfect. So what Clarence has said, which is a depot medication, all that means is you're depositing it via an intramuscular injection. Lithium doesn't have an IM version, same with clozapine. Clozapine does have one, but they're trialing it. It's not actually licensed yet. So you'd probably be using an antipsychotic for that. So things like paliperidone, which is an IM relative of risperidone, olanzapine, but that's your sort of last option. Right. So that's us for today, for this evening even. Pretty please give feedback, because I look at it every time to make sure I make things better for you next time. Let me just stop the recording. So yeah, feedback would be really, really appreciated.